Good evening. Yawarat Bash. It's a great pleasure for me to be with you this evening in this elegant conference. Our patient is a middle-aged, overweight gentleman. He has a lot of conventional risk factors, including hypertension. He's a heavy chronic smoker, and he has dyslipidemia. This patient has been present to the emergency department with severe central chest pain, and the ECG at that time showed 3 millimeter S-segment depression in the anterior chest leads. And the echo, bedside echo, shows that there is good LV function with some septal hypokinesia with no valvulopathy. There is no any abnormal lab value apart from more than 24 increase in the high sensitive serum troponin. This is the baseline angio. Showing that the RC is dominant with no significant stenosis. And if you have a look on the left system, the left main stem seems to be good, and LCX is not bad, and we have a tight lesion in the early mid lesion. Honestly, this patient have been labeled as a case of non-ST acute coronary syndrome with a very high serum troponin. That's why the early invasive management have been opted, and he transferred to the cath lab. And as a usual default procedure, the patient have been uploaded with a prasugrel where after diagnostic angio and ad hoc PCI have been decided. JL guide catheter at that time, or workhouse wire, heparin, pre-dilatation DS, and post-dilatation as a default procedure. Till now, the patient in this case have been done by one of the fellow, and I was preparing to have my coffee in the control room, and used the JL catheter, fortunately. And in this stage, everything was good. He was trying to cross the lesion, but it seems that he faced some problem in crossing the wire distally. And if you have a look on the guide catheter, still is not engaged, so it means that possibly he make a lot of force or to engage the guiding catheter. Out of the blue sky, the patient crashed on the table, and with hemodynamic compromise and ST elevation or precordial chest lead. So what we see in that, the patient get that, and we have this angio. If you have a look, there is TME zero flow in the left system, and we have got a white area in the beginning, in the ostium of the left main stem, extending to the ostium of the LCX and the LAD. Here, and unfortunately, the wire have been withdrawn from the left system. So we have got this. The patient is almost always crashed, and there is no wire inside. So what happened? What happened to the patient? Why out of blue sky everything is good? It's trying to cross it's like to be type A lesion, and the patient crashed off table. So it's either a spiral dissection to the left main stem, it's air embolism, or it is spasm. Whatever the cause, if you have a look there, we have this white area. This still seems to be a beginning of the dissection due to the guide because of the excessive manipulation for the guiding, because the guide couldn't be engaged well, and there is a provocation of the dissection from the guide. So what's happened here seems to be clear in the cartoon, that whenever we have got this the dissection after injection a lot, after every injection, we are going to make the more intramural hematoma, and you'll go to obstruct the flow to the left system totally. This is exactly what happened in this case. So the patient should be, and he's collapsed, and VTAC and atago-VFib. I think we gave several DC shock, CPR, and we start vasopressor for this patient. So what's the next? What shall we do with this patient? He's crashed on table. There is no any flow on the left main stem. Shall we put ECMO, intra-aortic balloon pump, or devices, impella? Shall we call for emergency, send the patient for emergency surgery? Shall we try with the PCI? If the PCI, shall we shift to the femoral, changing the guiding catheter, or we can do the PCI with the same or medical treatment? I think that the time is very precious because we are dealing with a crashed patient on table for a type A lesion, and we don't have enough time for implanting ECMO or sending for emergency surgery. So we try to wire with the same guiding catheter to try to wire. Unfortunately, after a few seconds, we can cross the wire distally. So at this time, if you cannot get to have the wire distal to the LAD, put it anywhere. Just we want to have some flow to the left system. So fortunately, after that, it was very easy to cross the wire to the distal part of the LAD, and this have been followed by implanting the stent in the mid and proximal LAD. There are some tips for crossing the wire in the dissected vessel. This is the parallel and stroke technique. By this we mean that whenever you have got dissection, because we have got a lot of intramural hematoma, if your first wire go to the false lumen, however, in this case, we haven't used this technique because we could cross the wire. At the first wire going to the false lumen, please keep it there, and try to take a second wire and to put a microcatheter in the wire with the negative in the false lumen. Try to aspirate the blood, and that time it will expand the lumen and will decrease the intramural hematoma and hope that you can cross the wire through lumen. And it's well mentioned that try to use OTUW wire balloon just to inflate before the true lumen, because it will keep the hematoma away from reforming. So this is one of the technique that can be used for crossing the true lumen and dissected vessel. So after that, we have put a stent. We are relaxed and we have a deep breath, and the patient become good hemodynamically. We have put a stent in the left main stem to the LAD, and there are also some tricks for stenting for the dissected vessel. Stenting for dissected vessel is not the same for stenting for the non-dissected vessel, because there are a high rate of complication, because whenever you are putting a stent, there will be a propagation of the intramural hematoma to the extent of that section, and definitely later on, after a period of time, when there is resolution of the hematoma, there will be late-stage malposition. That's why do not be aggressive, not predilate. If you have a timion flow, never predilate, just put a stent and avoid predilatation. But in cases that you don't have a flow, it's TMI's flow, definitely you should have some sort of predilatation, but you shouldn't be so aggressive. And do not oversize the stent. Consider IVAS is available, because it's very important, because oversizing of the stent will push out the hematoma, and the dissected vessel diameter is hard to be assessed. If the IVAS is available, it will be very good. And please do not never inject when you have got dissected vessel. Use the longer stent as what's available on the shelf, because this is a pinning in hematoma, prevent extension of the section. And there is one concern, which is preemptive stenting. It means that you should stent from the healthy to healthy. So try to choose the longest stent that available on the shelf. Do not be panic about that. Take the longest stent. Just we want to close from the ostium to the path. So from healthy to healthy should be covered. And less aggressive, do not do post-dilatation unless you can see that the result is not so good. So after that, we have this result. We have TME3 flow on all the left system, but we have some pinching in the LCX. And we know that this is dissected, so we don't have IVAS. That's why at that time we have some discussion with some colleague. Shall we stop, or is IVAS not available at that time? So we have proceed doing a stenting, and we have used normal tab technique, and lastly we have got this result, and this is the final result for the patient. So the take-home message is that do be very, very precise, or you should have a meticulous guiding catheter. Never do roofing for the guiding catheter. Whenever you have got your guiding catheter is touching the roof of the left main stem or any vessel, definitely when you inject, you will get dissection. All the time when you're going to inject, when you have got engaging, before you inject, have a look on the pressure. If you have got down pressure, never inject. It means that your guiding catheter is touching the roof of the left main stem. Whenever you have got coronary dissection, please do not inject. Do not inject. Do not inject. And disengage the catheter, and non-selective shoot is the best way. For wiring, for ostial dissection, use less penetrating guiding catheter. Judkin is the best way. Please avoid deep-seated guiding catheter like EBU and XL, and parallel stroke technique is one of the good. And for the CTO operator, sometimes you cannot cross the wall distally with antegrade. You can choose some retrograde technique like stroke grade retrograde technique. And stenting, as we said, long stent, do not oversize and have a longer stent usage on the shelf. And thank you so much.
Great, thank you.